Good evening, Dr. Gite. I think we should start now.
Yes, sir. Yes, sir. We can start, sir. We can start,
Yeah.
sir.
Yeah. So today, Ankit,
Yes, sir.
Ashay, and Samit, they are answering.
Good
Yes,
evening.
sir.
Good
Yes,
evening,
sir.
sir.
Good evening, sir.
Good evening, sir.
Good evening.
So can I start?
Yeah, please start.
A 55-year-old male patient presented with complaint of right flank pain since 2 weeks, hematuria since 10 days, burning micturition and increased urinary frequency since 3 to 4 days.
So, Ankit, now these are the
Yes, sir.
key symptoms. What are the questions you would like to ask?
Sir, since the patient has presented with three key complaints like flank pain, hematuria, and burning maturation, I would like to elaborate each symptom separately. Coming on to the flank pain, I would like to elaborate according how the pain started, onset, duration, progression, whether the pain was associated with nausea or vomiting, or whether it was there was any aggravation or relieving factor, or whether it was radiating, whether there was radiation or not. And coming on to the hematuria, I would like to ask whether the hematuria was painful or painless. It was initial, terminal, or complete, or whether it was associated with any blood clots, or whether it was associated with any fever or any other apart from these increased frequency, whether it was associated with any lower unit tract symptoms or not. And then that's it, sir. And yes, sir. According to elaboration of the symptom, I would like to ask these symptoms.
So he already has got urinary frequency, and so he has got a LUTS. So
Yes,
you
sir.
don't want
Storage.
to elaborate the history for LUTS?
Yes, sir. I would like to elaborate for the storage LUTs, how frequent he was urinating, day and night time frequency. Day and night time frequency I would like to ask, and I also ask about the urgency or urgent incontinence, and whether it was associated with any lower voiding LUTs or not.
So,
Okay.
Ankit,
Yes, sir.
you started well with the pain, but then suddenly you jumped into associated symptoms. You know,
Yes.
so once you start with pain, then you should evaluate the pain completely. What type of
Okay.
pain? Continuous pain, colicky pain, sting pain. Once you finish with the pain, then we go to the associated symptoms. Like you went with hematuria, you went very well, right?
Yes.
And with the third point, like sir said, if there is any low unit tract symptoms, then it is better to evaluate the entire uh, low unit tract symptoms with the scoring.
Yes.
Okay, go ahead.
So whenever you listen to the chief complaints from the patient, and after elaboration, you must have at least 2 to 3 clinical diagnoses in your mind, so that you can ask negative as well as positive history. Otherwise, everything will be haphazard, and in exam it will be stuck at that place only.
Absolutely. So keeping sir's point in mind, now go ahead and ask. So what all is coming into your mind? You tell two things, Ankit, Akshay, you add, and Samit, you also add.
Sir,
If there,
as per the age of the patient and as per the chief complaint of the patient, my differential diagnosis would be urolithiasis or urothelial malignancy and UTI.
okay, Akshay, you're thinking of anything else?
No, sir.
So why you are thinking urolithiasis as a first diagnosis? What are the positive findings till this stage in complaint as well as negative history? म्हणजे so
Sir,
age is 55 years.
yes, sir.
55, correct.
Age
Hmm.
and the flank pain and associated with the lower unit tract. This may be due to lower
No,
ureteric
flank pain can
calculus.
be there in malignancy also, no?
Yes, sir. Sir, I would like to ask about the negative history. I would like to elaborate. After that, I will be in the position to say my.
Okay, so these 2, 3 things are coming in your mind.
Yes,
Okay,
sir.
Yes, sir.
okay. Give him the negative history.
Okay. So let us say Asai and
Yes, sir.
Samit, do you have
Yes,
any
sir.
differential diagnosis? You also agree only that it is urolithiasis?
Sir, first I will consider right obstructive uropathy due to a calculus, and then UTI or acute right-sided pyelonephritis, and third I would like to keep as malignancy, either RCC or this UTUC, and then it can also be BPH along with UTI,
So Samit,
pyelonephritis with BPH.
Sir, I would like to keep first as a urolithiasis, stone disease only because of the positive symptoms of flank pain, hematuria with burning, and low urinary tract symptoms. Then second, I would like to keep as a differential as a mass, could be a urothelial malignancy.
okay. And
So this two
so there
may
can be one
occur by
diagnosis
phenotype.
or there can be double. it can be a multiple diagnosis also, no?
I'm
Yes.
happy that Akshay
Even
also thought
55
of
years old,
BEP.
so he might be having double
Yeah, Akshay
Problems.
thought about it. I'm happy
different.
about that. Good.
Good. Okay, so Akshay, what are the other negative questions or history you want to know?
Sir, on like after HOPI, I would like to ask about negative history of lithuria, then pyuria, and also for history of fever with chills. And I would also like to ask about smoking history and like occupational exposure or something, history of weight loss, history of loss of appetite.
वो सब तो
Then,
पर्सनल में आ गया ना बेटा. अभी
Sir,
you
I
have
want
asked about flank pain. Go
uh,
more into
whether
detail
it
of
was.
pain, hematuria, and LUTs.
देखो,
Then you go to personal.
if you have 3 to 4 diagnoses considering
mm,
the pain, hematuria, and LUTS. So
mm,
pain, hematuria, and LUTS means suppose you are thinking one stone disease. Another
mm,
is, for example, hematuria है तो malignancy, upper tract, lower tract. उसके
mm.
बाद में और कुछ हिमेचुरिया का और तीसरा या चौथा जो भी है तो उसका उसका एक सेंटेंस में 3-4 सिम्टम्स पूछना चाहिए.
So whether the
Okay, sir.
flank pain was associated
Sir.
with any nausea and vomiting.
अदरवाइज क्या होता है
Sir.
कि निगेटिव और पॉजिटिव हिस्ट्री हैप्पीसाइडली अगर पूछ लिया ना तो एग्जामिनर को भी कुछ नहीं कर समझेगा और तुम क्या पूछ रहे हो उसको भी नहीं समझेगा.
Sir, so to rule
See,
out stone
all
disease,
three of
I would
us,
like.
whether all three of us, Gaurang Shah sir, Gite sir, and me are saying the same thing, that go one by one rather than haphazard.
Mm,
So
एग्जैक्टली एग्जैक्टली.
this is what we want from you. That once you started pain, finish it completely, finish the hematuria completely, finish the LUTs completely. Then you go to associated symptoms. Then you go to personal history. Don't start with pain and then say associated अरे fever है कि नहीं अरे बाबा पर पहले pain तो evaluate करो ना. And by
So
this time, then you get to something in your mind that what is going on. Go
so
ahead now.
we have given you that two clinics of symptomatology, no?
Hmm.
So in that again, if you go through whenever you are going to present, na, you are going to
For
answer.
last time we
I
gave you so
request all
much.
of you to go through that thing plus your
Yeah.
dance and whatever it is, other books you are referring, and be prepared. You should know
See,
exactly what are the questions you are going to ask.
when hematuria word comes, the examiner will expect you to go into detail of hematuria. You cannot just say one or two lines and hematuria has got a
एग्जैक्टली सर.
hematuria has got a protocol. You have to follow it.
So if you are thinking hematuria means you have to again take the history related to the malignancy also. Malignancy means localized malignancy, locally advanced malignancy and metastatic malignancy. ये एक साथ में अगर 5-6 पॉइंट बोल दिए तो he is thinking कि भाई you are talking
Absolutely.
about the malignancy only. Then you are talking about stone disease मतलब stone के साथ क्या क्या हो सकता है वो symptoms एक लाइन में अगर आ गए तो वो stone disease. तो ये हैप्पीसाइड नहीं
See,
करना है मुझे मुझे मुझे
we are giving you topics so that you prepare the topic. It
एग्जैक्टली.
doesn't mean you come with a biased mind that this is a stone case. ऐसा मत सोचो. We will take it to malignancy and end the clinics there. Chalo, go ahead, guys.
Rahul, go ahead.
Yes, sir. The patient was relatively asymptomatic before 2 weeks when he started developing right flank pain, which was intermittent, dull aching in nature, moderate to severe in intensity, radiating towards the groin, and partially relieved with oral analgesics. There was no definitive aggravating factor and no associated trauma. He also complained of intermittent gross hematuria for the past 10 days, which was painless, not associated with passage of clots, and was occurring throughout the micturition. Additionally, the patient developed burning micturition and increased frequency over the last 3 to 4 days.
Go ahead.
Patient is a known case of hypertension and diabetes and is taking Telma 40 and Glimepiride 1 milligram for the same. Family history is non-contributory. Personal history diet is mixed. He is a non-alcoholic, non-smoker, non-tobacco chewer. Rest of the other things are normal, sir.
Is
So
it
the
important to
next
know
question,
what diabetic medication is taking?
Yes, sir.
Yes.
Why?
The SGLT2 inhibitor is known to cause glucose urea. So
Very good.
there is a chances of recurrent UTI.
Very good. Not only UTI, sometimes they come with pyelonephritis, phimosis, so commonly we see.
Yes, sir.
Okay.
Yes, sir.
And even any history of antiplatelet if is taking on.
Very, very important.
Okay, fine. So, Ashay, now this is a history. As you know, the differential diagnosis is not going to change. As everyone of you are saying that it can be urolithiasis, it can be secondary to obstruction,
Malignancy.
Instruction.
malignancy, obstruction, double pathology, or it can be sometimes it can be very rarely it can be a renal cyst with the infection and bleeding inside it.
Yes.
Obstruction can be because of tuberculosis
Mm.
also,
Uh,
right?
yes,
Yes,
sir.
sir.
So these are the differential diagnosis that is coming in your mind.
So, sir has given me one. Sir's uh, sir has given me one question now. So, what all are the causes of flank pain? Evaluate now. What all you will think of?
Because of could be any stone. So
One,
because of
urolithiasis. Go ahead. Go ahead.
yes,
Quickly, quickly.
So
any
pyelonephritis or
Pyelonephritis,
nephritis or any
malignancy.
pyelonephritis,
obstruction to
malignancy.
the UJ obstruction, or maybe there is obstruction to the slit of papilla or blood clots.
Okay.
Then ureteric stricture causing back pressure changes, which causes hydronephrosis and which may cause the aching pain.
Renal abscess, perinephric abscess.
Blood stress.
So, I would go from benign pathology, infective
From
pathology, malignant pathology. If you don't want to miss out anything, this is the way you should divide it. Benign pathology, what all could be the causes? It could be stone
Okay,
disease.
urolithiasis.
It can be
In
PU junction
stone,
obstruction. It can be
UG
Obstruction.
stricture.
obstruction.
It can
slough
be
of
cyst. It
papilla.
can be pelvic cyst. Right. So
Mm.
all the
Yes, sir.
benign causes. We start with what all I said: stone disease,
Stone disease.
PUJ
obstruction. That could be
obstruction.
stricture
PUG
in
obstruction.
the PUJ. It can be stricture in the ureter. It can be uretrovesical junction obstruction. Okay. Then it can be low urinary tract obstruction causing upper tract pathology. So all the benign causes, okay. Then you
Yes.
can say cyst, parapelvic cyst. Then you go on to the infective causes. So
Mm.
pyelonephritis or
Renal abscess,
infected
perinephritis.
hydronephrosis,
Perinephric
abscess,
abscess, renal
Yes.
abscess.
perinephric abscess. So
Mm.
infective. Then you go to malignancy. What all are the causes when you get malignancy? You have a
Renal
RCC,
mass or
UTUC.
correct,
SCC
UTUC, RCC, or clot retention on the upper
correct,
or
tract.
any
correct.
vesico-ureteric junction mass which can cause back pressure hydronephrosis because of that.
So at every stage, we are dividing this in our mind. No? You will not miss the causes.
Yes, sir.
So when you start with pain, then you have evaluated pain. When you start with
Mm.
hematuria, you evaluated hematuria. When you start with causes, you evaluate causes. But this kind of classification should be there in the back of your mind, so that you
Mm.
don't miss anything. And again, from up to down, everything. Okay, from
Yes,
kidney
sir.
to lower tract.
Yes, sir.
Very good. Chalo.
Okay, so Ashay, now what you want to do?
Sir, I would like to examine this patient.
Yeah, Rahul, go ahead.
Yes, sir. General examination is patient is conscious, cooperative, and well oriented. Weight is 74 kg, height 168 centimeter. Pulse is normal, blood pressure, respiratory rate, SpO2, everything is normal. No evidence of pallor, icterus, cyanosis, clubbing, or lymphadenopathy or edema. Head to toe and spine examination are grossly normal, sir.
Okay, go ahead. Finish your examination, total examination.
Yes, sir. Per abdomen findings, it's a flat abdomen, centrally placed and inverted umbilicus with normal respiration, no scar or sinuses or dilated veins, no visible swelling or renal angle tenderness, no visible peristalsis or pulsation. Hernial sites are clear. Genitalia is circumcised, sir. On palpation, normal temperature, mild left flank tenderness is present in the patient. No obvious palpable lump. Hernial orifices are normal. No cuff on impulse. No deformity on the spine. Genitalia is mentioned, circumcised. normal scrotum, testis, and penis.
Anything positive?
Except for
Left,
mild left flank
flank.
tenderness, sir, nothing, sir.
And for rectal examination?
Yes, no procedure
Normal.
regarding.
Normal.
Normal, sir.
Okay, fine. So, Ankit,
Yes, sir.
this is a history, this is a examination. Now, what you want?
Sir, 55-year-old male presented with left right flank pain with hematuria and burning maturation on examination, general examination, which was essentially normal. And on systemic examination, there was mild right flank pain but tenderness. So I would like to order some tests like CVC, RFT, urine routine, and microscopy. And as an extension of my clinical examination, I would like to go with USG whole abdomen with pelvis.
Anything
And
else?
then And since patient is also having burning maturation and my differential diagnosis is UTI, I would like to have a urine culture also. And and the second, my diagnosis was also urothelial cancer. So I would like to have urine for malignant cytology if there is no hematuria present at present.
Mm. Blood sugar also.
And
Coagulation
Then
profile.
HbA,
Blood sugar
serum
and
PSA.
Coagulation profile.
okay, serum
population
PSA.
profile.
And if you are
Since
asking for a
since on
PSA,
DRE, so since DRE, there is no suspicious of any uh, growth in the prostate. So I would at the present
Mm.
time, since I am having a suspicious of UTI, so at
Mm.
present time I would not advise for serum PSA
Mm.
level.
very good, fine. So, Samit,
Yes, sir.
Ankit is saying that he is not going to advise PSA. What is your view? Samit,
So, sorry, sir, can you repeat the question, sir? Actually, network.
see, Ankit is saying that he is not in favor of advising PSA.
Yes, sir.
What is your view? In this patient, will you like to advise PSA?
Sir, considering the symptomatology is having burning, so there might be some component of UTI. So, if the PSA would be ordered, the it could be enlarged, and as there is no suspicious findings on any DRE, so can hold PSA till the UTI or till the symptom subsides, and then after that evaluate for it, sir.
Okay, fine. So we will not order PSA. Anything else? Because he has got a lower unit rate symptoms,
I would like to have a Euroflow for the patient to look for
Europlometric.
his. Yes, sir.
Okay, fine. Go ahead. Rahul, show them investigations which they have asked.
These are the investigations, and all shown them in bold. Serum create is elevated, that is 2. HbA1c is 10.5. Uric acid is 10.3. Serum PSA is 0.57. Electrolytes are normal. PTINR is also normal. Hemoglobin is 15.2.
The sodium is marginally low.
Yes,
Yes.
132. Yes, sir.
Yeah. So Ashay, now, okay, sonography you have to show them.
Yes, sir.
And Europlometry if you have done. So
So
this
this
is
is a
urine.
urine routine micro of the patient.
Have you done culture and sensitivity? No growth. Show them ultrasonography. So who is going to read this ultrasonography? Ashay?
Sir. Mm. This is a
Excuse me.
ultrasonography
No,
of
no,
a
no.
55-year-old male in which I can see the liver is normal and um, bla urinary bladder is normal, smooth contour, and prostate also looks normal, and the bo both left and right kidneys are showing multiple calculi with acoustic shadowing, and Moderate hydronephrosis in both kidneys.
Mhm.
This is USG whole abdomen, which showing liver and gallbladder appears to be normal with with mild intrahepatic biliary dilatation, and bilateral kidney show radiopacity with posterior acoustic shadowing, along with my
Radio opacity.
Hyper.
Sanket,
sir.
I will request all of you. I will request all of you that please
Sorry.
make sure if you are reading X-ray, then say accordingly. If you are
Yes, sir.
seeing sonography, then say accordingly MRI
Yes, sir.
and CT scan.
Yes,
Everything
sir.
you understand. This is very important. So every time you see X-ray, think about X-ray. Okay, what you are going to say like that. Okay, tell what you are
Urinary
saying.
blood. Urinary bladder seems to be adequately distended with no evidence of any bladder wall thickening. The prostate, there is mild intravesical prostatic protrusion of the prostate into the bladder. There are multiple renal calculi seen along with the dilated callus seen in bilateral kidneys, sir, with maintained CMD.
Okay. Now show them the report.
Both kidneys are normal in size and appearance. The right kidney measures 12 by 5.5 centimeter with a staghorn calculus is noted. Left kidney measures size 9 by 3.3 centimeter with a few calculi, largest of size 22 millimeter at the lower pole. Prostate is 26 grams and appears normal in size. No focal lesion.
So my question is, can you say on sonography that there is a staghorn calculus?
Mhm.
So yeah, Samit.
Sir, if it is a large calculus occupying the pelvis and all the three calyces, then the radiologist must have thought and written it
Many
as a
times,
star.
many times
So
they can give if the sonologist is good. He can show that it is nicely occupying all the
Mhm.
system.
Mhm. If the
yeah.
branching
So
is
now
seen.
tell me, yeah, what is the definition of staghorn and what are the different grade or stay of the staghorn?
Sir,
Sir,
Sir, it could be a
staghorn is
partial
between.
staghorn or
partial.
a complete staghorn. Partial is the pelvis with one calyx, and complete is more than
Two
one,
or
all
more.
the calyx with the pelvis.
Mm.
Okay. So in this case, it is possible for them as a sonologist, as Dr. Hiren Sodha said that, if he can demonstrate different calaceal stone with a pelvic stone, definitely he can say. So now, have you done the uroflowmetry, Raul?
No, sir, we have not done the uroflowmetry in this patient.
So next what?
Since the patient is on ultrasound, there is right staghorn calculus along with the bilateral renal with left renal calculus. I would like to have a CT urography of this patient.
Sir, creatinine is too,
Creatinine is
so
Creatinine
high.
is too high.
Creatinine is
We
high.
like
non-contrast,
to
True.
have
sir.
True.
a
True. True.
plain
True.
CT,
Plain CT. NCCT KUB, sir.
NCCT
NCCT
KUB.
KUB.
So,
So,
please
sir asked for
understand.
Euroflowmetry. Would you all have asked for it?
Sir, I would have definitely wanted to have a Euroflowmetry, so that I can get.
But sir, considering there is burning in urine, he's having UTI, so that would results won't be accurate. So we can evaluate that after he's treated with the underlying disease he's having.
Then how will you know? Then you don't have a baseline study.
Baseline, I won't have.
So, sir thought of something and therefore asked you for Euroflowmetry. Huh? You should also ask. There's no harm in getting a
Yes,
Euroflow.
sir.
What is the problem?
Non-invasive and
Yeah.
yes,
You've got
objective
symptoms, no?
measurement. Yes, sir.
Hmm. ठीक है, sir.
Okay. So even if you are answering, na, if the creatinine is raised and all, so please remember in exam also. Okay. Don't make
Yes, sir.
this mistake. Fine. Sure. CT scan.
No, so
Yes, sir.
my question before you show the CT, how many of you will ask for non-contrast out of the three of you? Or you all three want contrast CT?
Sir, since creatinine is 2, I would like to ask for
No,
non-contrast CT.
suppose creatinine was normal.
Sir, then for
I
evaluation
will.
of renal cal, I would ask for CT urography.
What is your
Contrast.
explanation, Akshay?
Sir, it will give me better anatomical delineation of all the calyces and also the function of the kidney.
Anything more in anatomy?
So
That is what I want
retrorenal
to.
colon
Uh,
or anything.
Colon.
Anything
that
more?
can be done in
Sir,
NCCT also.
anatomy of the pelvic lysis system and lower
Uh,
pore anatomy. Infundibular length, I would be in a better
uh,
position to gauge
mhm.
with CT
Anything more?
urography.
Width and
Anything more?
this
Any infection
No, no,
complication.
no. Anatomy, anatomy. Anything more in anatomy?
surrounding
Any
structures.
diverticulum, calacial, or any other.
Why you're
Uh,
not thinking of congenital anomalies
Yes.
or
Yes, sir.
differences in the system, bifid system,
That's
Duplication.
when you
Yes,
think.
duplication.
double ureter,
Yes, sir.
horseshoe kidney? Why you're not thinking of all these things? Of course, sonography would have shown that, but
Hmm.
some surprises. Huh?
Yes,
Yes.
sir.
So anatomy. I was asking. So one is anatomy related to the system itself.
System.
Second is the anatomy in relation to your procedure planning.
Yes, sir.
That's where the retrorenal cone. Again, in your mind, make these things in your mind. One is regarding the system, whether you want to do RIRS, PCNL, what is the infundibular length, how is the
Hmm.
system, whether it's a spastic system, whether you will be able to reach there, whether you will be able to reach the lower pole, how you
Yes,
will
sir.
plan it. Huh? Opposite kidney. Then the anatomy related to your
Hmm.
procedure, and then the function. Okay? Chal.
Go ahead, sir.
Yeah, go ahead. My question to all of you: how many of you practically? I'm asking you.
Hmm.
All of you will like to have X-ray.
Yes, sir.
Yes, sir. Pre-operative, I would like to
Preoperative one.
baseline for it helps in explaining the patient also about the disease.
And in your institute also, you do
So yes, sir.
X-ray or you
Yes,
don't do
sir.
X-ray.
Pre-operative, we do X-ray.
So we do an X-ray.
Okay, this is just a practical thing I'm asking.
So many
Okay, show
times in
them
the
X-ray.
past, now
Show them
when we
CT.
were not doing IVPs, that time also we used to say X-ray and sonography are complementary to each other. You get a lot of information from sonography, you get a lot of information from the X-ray. So you get
Yes,
to see
sir.
the bone density, compare it with the density of the stone. Then you get to plan how many ribs are there, how you'll take your puncture. So many things you get. Hmm?
Yes, sir.
So this was the X-ray view of the patient.
See, so
Hmm.
nicely you can see such a complex stone. Huh?
Hmm.
Okay, show them CT.
There is another image after this, sir.
So who is ready?
So this is
Hmm.
plain CT of abdomen and pelvis. So can I get a previous slide? Yes, sir. This is a plain non-contrast CT of abdomen KUB region, which liver and gallbladder appears to be normal. Stomach is well distended. There is a radiopaque density occupying the in the right side. They occupying the renal pelvis along with the extension into the upper and middle calyx, and on the with well maintained parenchymal thickness. And on the left side, sir, there is a staghorn calculus which is occupying the renal pelvis and the lower calyx. with well-preserved parenchymal thickness, sir.
See, when you said liver, then you should also tell about spleen.
Go.
Okay,
Yes,
both are
sir.
Solid
important
organs
for us.
appear
Both
normal.
are important
Normal.
for us because if there is a hepatosplenomegaly, then while planning your puncture, it is very important. Remember that.
Yes.
Okay, sir.
Okay.
You have to look for these things. Nobody is going to tell you that there is a hepatomegaly or a splenomegaly. But then during the puncture, you will not have that in your mind and you will puncture the liver or the spleen. That will be a grave complication. So you have to
Yes, sir.
look for that. So when you look at liver, look at spleen also. Once you have seen it, then it will be there in your mind. Then during surgery, it will come into your mind that I have seen it.
So
Yes, sir.
Samit, now how will you judge the complexity of this stone?
Sir, it is a complete stagon stone, which is this bilateral complete stagon stone. Uh, so
Bilateral complete? Show me X-ray. Would you like to change your diagnosis?
Anyway, I was not happy with your answer. When sir asked you a question like complexity of this stone, there should have been several aspects to this answer. One would have been unilateral or
Size.
bilateral. Okay. Second would be the characteristics of the stone. That is the size, the shape,
Density.
the density, the composition, the volume, and whether complete stagon, partial stagon, and then comes the pelvic axial system.
Ankit, you can answer if you have.
Sir, we can judge the complexity by seeing the whether it is occupying the whole of the pelvis or whether the it is how much it is extending into the calyxes, and we also have a scoring system for the Stagon calculus, like Guy's scoring system, Crow's scoring system. So accordingly, we can make up we can quantify the complexity of the stone.
Very good. Elaborate more on that.
Sir, Guy's scoring system is based on the number of stone and anatomical factors like grade one is a single calculus in the lower pole or in the upper pole,
Mid or lower. Hmm.
mid or lower, sir.
Mid.
And grade five, it is either in the solitary kidney, Stagon calculi in the solitary kidney, or it is occupying a whole of the renal pelvis along with the calyceal system.
Very
So
good.
there
Yeah,
are
Akshay, you
four
want to
grades.
elaborate
So
further?
sir, one is stone in the mid
Simple.
pole or lower pole, and two is a single stone in upper pole or in pelvis, and three is partial stagon, and four is complete stagon.
Okay. So what is the importance of this?
Sir, so higher grade is more complex stone and more complex PCNL,
No,
and
so
lower
what?
stone
Complex
free
stone.
rate.
But what
We
do you
can counsel.
understand by that?
We
Counseling
can
and
counsel the patient.
staging.
We can counseling the
He
patient.
will make
We
require multiple procedures.
so it will be helpful for us and to counsel the patient regarding the surgery and regarding the need
No,
and
no. So
regarding the
see,
need.
ठीक है, you told counseling. So in counseling, what will you tell?
Sir,
so
in
that does
counseling we
require
will
multiple sittings.
first
Multiple punctures
So
and
go,
multiple
staging.
go, go,
settings.
go slow. One is you will tell about the number of tracks, right?
Hmm.
Yes.
You will
Yes.
talk
Yes.
about bilateral, unilateral first. Then you will talk about doing
Stage
one kidney
procedure.
at a time or the stage procedure. And
Yes, sir.
then you will talk about the number of the tracks. And staging may be a few weeks apart or 2 days apart. You can keep the nephrostomy and do it also. Okay, so this is how it will help the complexity. Yes. Okay, go ahead now. What else you want?
So basically, when you see
So skin to stone
something like,
distance.
when you
Mm,
complexity means what? You know that how difficult it is going to be. Number one,
mm,
what are the chances of having complications
mm,
related to your
Correct.
procedure?
Mm,
You understand?
Mm.
And third and most important thing is then how you're going to counsel the patient regarding the procedure, the type of procedure, whether you will be having a one or multiple, one modality, multiple modalities. What are the chances of stone being left behind, or he may require a multiple, and what are the complications? Understand? So this
yes.
is very important. So what are the things you are expecting? Now this patient is with you. How you are going to counsel?
I will consult the patient regarding his disease process. He is having bilateral renal calculus along with raised creatinine, so he needs to surgery, and that will be in the staged way. We will first, we will plan for surgery first on that side in which he is more symptomatic, and there are chances it will be done. He will require multiple punctures, along with he may require staging in that kidney also, by looking at the burden of the stone. And I will tell him about the procedure and the complication associated with it.
So, Ankit, what are the
Yes.
different procedures you will like
Sir,
to?
sir,
Sir, I would also like to get a functional scan before operating.
operating the patient.
Yeah. So functional scan to overall
EC
this
scan.
thing is about 35 to 40 is the okay
Yes.
function.
Sir, so better kidney first.
Better kidney first.
It's almost same, not much of the difference.
So then the symptomatic
Then the
kidney, the right
symptomatic
side
kidney
would be the
file.
first.
Yes, sir.
Symptomatic kidney first.
Right kidney first.
Also, sometimes you
Ankit,
can also decide that which is the easier side. At least if
Simple procedure side
if
first.
both the kidneys are good and
Asymptomatic.
there is a solitary stone in one kidney, at least you want to safeguard one kidney before you take over the complex
Hmm.
case. Okay,
Yes,
so
sir.
it depends on the situation. Some of the things you said are correct, like symptomatic side or the better functioning side or all those things. But if both are equal, then you tackle the smaller
Simple.
load, which is easier. And in the
Hmm.
same sitting, you may plan to do bilateral also. If one goes well, you can go
Hmm.
ahead with the other if the stone load is not much.
Yes, sir.
so Ankit,
Yes.
Ashay, and Samir. The it was the GFR is 18 and 22. The right is 18, the left is 22. There is not much of the difference.
Hmm.
Okay,
Yes, sir.
and yeah, and partially obstructed system both. It is showing it is in a scan.
Hmm.
The patient has got a pain on the right hand side. How many of you will do right side first, and how many of you will do left side first?
We'll do on
So
the right side first, sir.
right
The
side
right side
first
only
for more
first.
Often
symptomatic.
first. Symptomatic and yes, sir,
Suppose if I say that I will like to do left side first because the stone burden is quite a lot and I have to do multiple sitting. So I will do left side first,
And
remove
then
as much as
stent.
possible.
we
Then
will
second time
during.
I will do finish the left side, and if everything goes fine, then I will the same sitting I will do the right side also. Suppose if you do right side, you are going to do only right side. Then you will do left side. You may not be able to complete. Then you will do the third time. I'm just asking you, how many of you in this scenario will like to do left side first or right side first?
Sir, I would like to deal with one kidney at a time,
Yes.
and at the max I will like to do right side first after, because it is symptomatic and the stone burden seems to be less in the right kidney, and at the same time I will put a degestant on the left side. Uh,
So
it will
Ankit,
be
you
it
want to
will
put a digest tent on the
left. It will
right
be
side.
Yes, sir.
No, no. So how many of you will like to put a DJ stand, or how many of you will do within 3 or 4 days you will do the second side?
Sir, first we will do the symptomatic side, and during that setting, I would place a DJ stand on the opposite side also, bilateral DJ standing, and in about 2 weeks, I can do the other side and remove the first stand and
I will go
exchange the.
if the first on the right side the procedure has gone well and the patient during the post-op is not symptomatic, he's not having any fever or the first surgery was uncomplicated. Then after 48 to 72 hour, I will plan for left PCNL. Or and we will counsel the patient either we will do in the same admission or after 2 to 3 weeks we will do the on the left side, sir.
Now, how much is hydronephrosis?
Not much, sir.
Are these both the
Not
kidneys
much.
are obstructed?
Sir, but you said functional scan is showing obstructed, so that's why I said
So
DJ
partially
standing.
obstructed. Sir, on CT
If the
scan there is
CT scan is not showing any
any
hydronephrosis,
obstruction. Yes, sir. There is no as such there
So
is no
there no evidence
emergency.
of hydronephrosis.
so still you want to put a DJ stand?
Sir, looking at the CT, I would just only
Report.
just
Also
because of
see
the
that.
DTPA
There is moderate hydronephrosis is there.
In the right and left has
uh,
mild.
my model process.
So all of you are going to do right side first, and there are multiple stones. Correct?
Yes, sir.
Yes,
I
sir.
was little, basically the stone burden is more on the right side, and patient has got a pain on the right side. So right side you want to do first.
Yes, sir.
Yes.
Yes, sir.
Correct?
Yes, sir.
And you want to put a stent in the left side at the same time.
Yes, sir.
Yes.
Ashay, you
Yes, sir.
agree with him? Ankit, you want to do the same thing?
Yes, sir. And there is also one thing written that but there is mild bilateral perinephric fat stranding. So, sir, there is
Better
some
to have
element of
stent.
better to have stent because there is some element of infection in the left kidney also. So I would like to have would go. I would like to go with right PCNL with bilateral DJ stenting.
So my next question is, this patient has shown that there is no growth, even though, correct, first cells or
Yes.
WBC is seen in urine,
Mm.
Yes, sir.
creatinine is seen. How many, Ashay,
Yes,
how
sir.
many days antibiotic you would like to give and what antibiotics you would like to give? Or you don't want to give? You can directly go and do the surgery. What is the
Sir,
literature is saying?
uh, sir, since there are pus cells, the urine culture might be false negative. So I would like to repeat the urine culture and also give empiric antibiotics. In our institute, we give oral fluoroquinolones before doing and BCNL.
We
How
can
many
go.
days? Let's go. Yes, Ankit, you tell.
Sir, as per the latest EAU guideline, any Staghorn calculus, we have to give prophylactic. We have to give antibiotic, and as per our institutional protocol, any patient of Staghorn calculus, we give fluoroquinolone orally for at least 5 to 7 days, and we will keep and after procedure we will give them for 3 to 4 days IV antibiotics. If and there is also a second option. We admit the patient and give 24 hour of broad spectrum. Since this is his patient, this his culture is sterile, so we will give him broad spectrum third generation cephalosporin, and during the post-op period 3 to 5 days of IV and 2 to 3 days till the time he is admitted. We will give him IV antibiotic and we will discharge him on oral antibiotic.
So Samit, will you like to wait till the pus cells becomes 2 to 3 or 4, or you
No,
can
sir.
operate?
No, sir.
No, sir. Under
Complete.
antibiotic cover only we will because the pus cell is unlikely going to be uh, reaching to normal. So after starting with oral antibiotic and under antibiotic cover, I would like to go ahead with the procedures.
But since it is a Staghorn calculus, there is some element of infectious stone is there. Steroid stone will be there. So
Steroid stone.
so there is less likely chance कि his urine
Is going to be sterile, sir.
urine microscopy with pus cell would not be like 2 or 3 or 4. Like it will be always there may be chances that it will be always on a greater side.
Sir, in drop also, I would
So,
like to send culture from the
Because
ureteric
from the
catheter and also stone culture.
so Ankit, I did the right sided. I decided to do it. I put the ureteric catheter, okay, and
yes.
the purulent urine came out. What should I do?
Stent and abandon.
So then I would like
No,
to go
sir.
ahead and
No,
place
no,
a
sir.
PCN.
PCN, yes, sir. I will
Okay,
place a
sir.
piece. I will
The
just
stent won't drain the stone burden according to that which is there. So PCN would be better, and so that
So
after
where
that
you
in the
will
near
put,
sir,
future.
after
Samir,
making a
you are
punch,
saying PCA.
sir, after
Where you
making a
will
punch,
put PCA? Upper, lower, middle? Which one? Which PCN will drain the kidney thoroughly? Yes, Samir? Ashay?
no, sir.
Sir, sir, according to the patient's CT, wherever there is obstruction and hydronephrosis, I would like to place it there.
So you're saying the CT, na?
Sir, but, so
Sir,
CT
after making
says moderate hydronephrosis in right. So,
Sir, after making an initial puncture, if the urine comes out to be turbid, then we will look in whether it is a turbid urine or frank pus. Sometimes it happens ki due to chronic obstruction, there is mild turbidity. If the turbidity clears off, then I will put in. Then I would like to proceed with the case
sir,
and
for gravity drainage, I would prefer posterior and lower
here
calyx.
Felix.
No, 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 no. For exam, if you find a turbid urine, it may be pus or may not be pus. Your best answer is I will place the PCN and come back. You do all these gimmicks in your private practice, not for exam. Okay, so your answer in exam is हाँ इनिशियल पंक्चर किया 1 सेकंड में क्लियर हो गया जस्ट 2-3 फ्लेक्स आए थे ऐसा सिचुएशन है तो ये डिस्कशन होगा ही नहीं तो एग्जामिनर हैज आस्क्ड मींस इट देयर इज अ इन्फेक्शन otherwise why he will ask and
Yes,
infected
sir.
hydronephrosis and pyonephrosis there is difference that everyone knows but in spite of having two either of one there you have to stop.
So, Ankit, you are doing well. My question is, I'm giving you the scenario. The once a little purulent urine has come, will you do three different punctures and put a small PCN, that is three PCN on the right side and degestanting, and you will go ahead with the left side, or you'll put only one PCN, or you'll put one PCN and one digestant and digestant on the right side and stop the procedure over there,
Sir, if
or
there
you
is
will
a
do PCN digestanting on both the sides.
Sir, I will. If there is a purulent collection coming out after initial puncture, then I will put a I would like to do PCN and put a digestant for maximal drainage. And on the left side, I would like to place a digestant and just come out. And we'll
So,
collect the culture and
Yes, sir.
Ashwin, yes, you send the culture. Ashwin, what will be your answer? What you will do?
Sir, so I will. The pus has
You know
come
the
from the
you
ureteric
you know
catheter
what
or
are the
the
things?
puncture.
Ashwin, I have
Yes,
given
sir.
you this scenario, correct? What are the different things we'll do? First of all, one person said, I just put a DJ stand and come out. Second person said, I will do PCN and come out.
Sir,
I
I
am
would like to
asking you
place both.
whether you will, one PCN may not suffice. So will you do two or three PCN, or you do PCN also and put a double gestant also on
Sir,
right side, and you go ahead with the left side, or on the left side also you'll put a digestant, or you'll put digestant on both the side only and come out.
Sir, I would like to place degestant on both sides and the put one PCN on the right side in the posterior calyx for dependent drainage.
Okay, and then that is not draining purulent urine then.
Mm, But then
Then we have to check whether
I will send intraoperative cultures and then keep the patient admitted and wait for the culture reports. Give antibiotic accordingly, and then if the counts and create are normal, I can go for a second procedure within a week.
sir, I would like, if the patient is not draining well, then I would like to see this position of the patient, whether it is whether
In
it has
situ.
malpositioned or not, or whether it has migrated. If it, then if after confirming the position of the patient, if it is not again it is not draining well, then I would like to put another PCN.
Mm.
So ideally, if you are saying that you want to drain, okay,
Hmm.
then the best will be to put multiple, because even during your surgery, you are not going to remove all these stones with one PCN,
Yes, sir.
right?
Yes, sir.
And you are just going to make a small tract and put. With this, the chances of patient going into urosepsis are not very high, and there are very high chances that he will improve a lot. Correct?
Okay, sir.
Yes,
Yes, sir.
sir.
So if you are suspecting this, then best answer is that okay, I will put bilateral digestion. I don't like want to in such a condition. I will not like to do anything on the left hand side also. I
Mm.
will do bilateral. I mean, digesting and right side multiple PCN if it is possible.
Sir, and
So
size
that
of
this
PCN?
multiple PCN will be of a great help to me. It will drain also all the different calluses, maximum drainage, maximum effect on the infection. And when you go for a PCNL, that time you already have a got a threat.
Yes, sir.
Okay.
Yes.
Yes, sir. So what should
Okay.
be the size of PCN that we should be putting? Just I have a query. Can we put a
So
single large bore PCN or
I'm asking you. I'm asking you what are the different PCN normally you put?
Normally we put 12 French or
So
14
12
French
to
40,
12
Malicot,
to 14 French
14 French?
So
Malicot catheter.
So
it
when
is
you
depend
go
built-in
into the
catheter.
puncture,
it is
go
depend
to the
on
puncture.
at what stage you have stopped the procedure. Number one. Number two, what is your purpose of placing the patient? So if your purpose is to drain only a infected urine, it can be 12 French is sufficient. If you have stopped the procedure after dilatation or you have done some dilatation, then you have made your mind and want to stop the procedure, then whatever the stage, you have to place as
That
per
size.
that stage. So there is no such fixed rule. If there is a clear pus, then white बोर 12-14 डिफरेंस इज सफिशिएंट उसमें कोई रेड रबर क्या बड़ा मैलिकॉट डालने का जरूरी नहीं बस भी रहा तो ड्रेन
Correct.
होने वाला डिजेस्टेंट से पेशेंट ज्यादा इसलिए है क्योंकि द
Both.
90% ऑफ द ड्रेनेज
external?
इज असाइड ऑफ द डिजेस्टेंट एंड
Yes, sir.
10% इज ओनली थ्रू हियर देयर इज अ बिग लुमेन ना 14
Yes,
फ्रेंच
sir.
और 12 फ्रेंच इज बिग लुमेन सो दैट विल सफाइस 28 और 24 फ्रेंच का ऐसा डालने का जरूरी नहीं बेसिकली फॉर द ड्रेनेज so answer should be it is depend upon the my aim of the drainage that is if frank pus or clear urine, infected urine, or at what stage I have made my mind to stop and place the patient. So as
Yes,
per
sir.
that, I will decide. But normally, usually 12 French or at the max some centers 14 French. उससे ज़्यादा कोई नहीं डालता.
So sir ने बोला है समझा ना?
Yes,
Now
sir.
number one, whether you are going ahead only for a drainage or you are going ahead with the removal of the stone. So if you are going only for the drainage and when you puncture, if it is an infected urine, 12 is sufficient. If it is a frank pus, then either you put 14 or 18 also, no problem, depending upon the how thick the pus is. If you are doing the procedure, suppose if you have decided to go ahead with the PCNL and then you find that there is a lots of bleeding and lots of problems are there, Okay, then during dilatation, how much you have done dilatation? Depending on that, you put the drain. So that is the answer, right?
Okay.
Okay,
Yes, sir.
so now Ankit, actually, we went ahead with there was no pus, nothing. It was not infected, it was not virulent urine. And the right side, we started doing PCNL. So at the end of the surgery, we did about 3 or 4. I'll show you the X-ray. I think we did 3 or 4 punctures, and at the end, we wanted to see that now there is a total clearance or not. So what we should do?
Sir, we can have a fluoroscopic guidance, and we can have a RGP by putting this dye from the UCAT and clamping the implant sheath, so
Occluding the
that we
MP.
yes, sir.
Okay, so that means three
And
different ways. One is endoscopy. So from
yes, sir,
endoscopy, you enter,
flexible
each and every
nephroscope.
calyx if
Can
possible. Correct.
yes,
Suppose
sir.
Yes, sir.
if the calyx is at a oblique or acute angle, what you will do?
Sir, we will insert a flexible
Flexible
nephroscope.
nephroscope.
Very good. So you have a flexible necroscope, and you'll try to enter into each and every calyx and see whether any stone is left behind or not. So that is internal. And you
Yes, sir.
like to do fluoroscopy. So in
Yes, sir.
fluoroscopy, if it is a radio dense, okay, you
Yes,
will
sir.
be able to
Yes,
see. But if
yes,
it is
sir.
a radio lucent, you will not be able to see. So then you want
Yes,
to
sir.
inject a contrast from below,
Contrast.
and you want to see all the calyces, right?
Yes,
Yes,
What
yes,
are
Yes.
sir.
the chances that in spite of doing all these things, still there will be a stone left behind?
So there are
So there are high chances because of
charges
the
because of the stone burden and because of the
burden is there. And
by looking at the CT and it is a household unit is more than 1,000. So there is chances ki there may be the while breaking while fragmenting the stone there are chances ki those stone may migrate to other calyx which is hard to locate and
So my question is to prevent that, what you will use?
so
This
you
is the
shouldn't
critical part.
fragment it too much. So we can use a larger amplas sheet and then retrieve like by minimum like you should
What
not
type of
fragment.
energy you will prefer then?
sorry
Sir,
sir,
What
didn't
type
get the
of
question.
energy you will prefer?
sir, here better
Sir,
would be dual mode
Uh,
combined.
more pressure, less frequency.
What?
So, sir, is
Pneumatic
any
lithotrip,
lithotrip.
also
lithotrip. Sir, I
any
would like to
recommend
Lithoclass.
go
any
lithoclass, sir. Ultrasonic lithoclass or cyber water.
any new technology where both can be
Your
Sir,
used?
combined
technology.
Ultrasonic,
cyber band shock pulse SC
cyber
or
and shock pulse or
Shock
and sir,
pulse or
there,
trilogy?
lithoclast
Trilogy.
ultra.
So
Trilogy
what
means
is
all
this
three,
called?
no?
sir, it is
EM,
ultrasonic,
So
sir.
dual mode lithotrip,
ultra,
sir.
Also
Trilogy.
trilogy,
and
EMS
ultrasound.
trilogy. That is ultrasound with
Yes,
lithoglast with
Suction.
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 Suction,
Suction.
simultaneous suction.
Mm.
So Samit,
Yes,
if
sir.
you use that, can you tell me how it works?
So like one there is a probe which acts like a pneumatic lithotrip, sir. It fragments and
So
There
pneumatic
is
is
only one probe.
so where is the pneumatic? Pneumatic goes outside or it is inside? Inside of the that sheet or the ultrasound.
so pneumatic is outside, sir.
So first the pneumatic is there. It is
And then
breaking the
inside there
stone
is a
into the bigger pieces.
ultrasound
Then the ultrasound is making it a smaller, and the suction
and
is
then
then
evacuating
sucks
it.
out the. Okay,
Yes, sir.
fine.
Yes,
So
sir.
Yes.
this is the, if you want to prevent migration of the stones in the small calyx where it is very difficult to access, then trilogy is the best energy
Okay.
for breaking and removing the stones,
Mhm. Yes, sir.
right?
Yes, sir.
Yes, sir.
Okay. So what is the EO guidelines or EO guidelines for a stag-on calculus
PC.
post-operatively? How do you follow? You have finished the procedure and patient is in the ward.
Yes, sir. So we will
Uh,
uh,
Sir, are there any
we will
residual stone left, or
tone. We will, yes.
So how will you find out? On the
so
table,
then
you thought that there is nothing else
Sir,
left.
Post
by
op
an X-ray QB, sir?
X-ray on this
Okay,
next day,
X-ray
sir.
QB is not
X-ray
showing anything.
QB,
sir,
or we
look
can
to look
even
for
do an
residual stones, NCCT KUB at 4 weeks.
NCCT QB.
At 4 week or immediately?
Sir, if we have any doubt regarding the residual fragment, first we will do X-ray QV, and if we are unable to visualize any any fragments in the X-ray QV, but still we have the suspicious, and based on our intra finding, then we can go for a NCCT KUB on the next day of the surgery, if the patient is stable.
The
If stable in the
idea is that before you discharge the patient, you want to give him the total clearance,
yes, sir.
and already the nephrostomy is in. So there are
Yes, sir.
very high chances that because of the blood clot or in the primary your surgery, you may have missed some small fragment, which CT scan will reveal, and you will be able to see it again when you put nephroscope through the earlier track, or you can
Hmm.
remove it.
Yes.
But now we have got some other gadget with us. And what is that? RIRS. So if
Uh,
the small fragment is left behind, okay, at the time of removal of the double
DJ
slit
removal.
scan, we
Indigenous.
can do. When
Check
RIRS was
RIRS.
not available, okay, when RIRS was not available, we were doing repeat
Second look.
CT scan, yeah, and second look TCN. Understood?
Yes,
Yes,
sir.
sir.
Yes.
Suppose you want to any other treatment you can give apart from only TCNL?
So then ECIRS.
Yes.
ECIRS. Yes.
Yes. So how many? All three of you agree that ECRIS will be better?
Sir, it will be able to prevent at least
Uh,
one puncture, one dilatation. We will have to do two, and then residual fragments we can clear with the ECIRS or the
ECIRS.
In
flexible
this
scope.
case, because it is a stagon, there may be some difficulty for the upper
Upper
callicial
calyx.
Upper
stone,
calyx.
supine position. Because in most of us are operating in the prone, so to go to the upper calyx and remove the stones in the supine may be little difficult, and the chances are very high that you might damage some other organ.
Mm.
Okay, so if you are very confident, then is okay. Then you can do the supine PCNA. Otherwise, better first you finish it off your prone PCNL. If required, second sitting. If very small fragments are left behind, or during the operation, you can use flexible nephroscope. Try to give the full clearance, and then you can do check RIRS later on.
Sir, if that is the issue, can we do prone ECIRS with the split leg position?
Yeah, but all these things are little difficult.
देखो you can do whatever
So
you want.
I'll
You can do
uh,
whatever you want to do, but in the
Hmm.
exam your answer is PCNL in prone position.
Yes, sir.
so
Yes.
I will tell you now that both the sirs have told you, like Dr. Gite sir said, it is not so easy. Okay. Secondly, what Gaurang Shah sir was saying, so I'm just seconding his thought. When there is a large stone burden in upper calyx or upper middle calyx, then what ECIRS is going to help you? If there is a major stone load in lower calyx and pelvis or middle calyx, then you can do a nice supine lower calycial or middle calycial puncture and
Hmm.
use flexible to get the satellite stones.
Hmm.
But if you have a large stone burden in upper calyx and middle calyx and upper middle calyx, then it's not so easy to do supine
PCNL.
upper calycial puncture. It's better to
Yes.
do conventional prone PCNL, and if some stones are left, you do check RIRS while
Check
removing stent.
RIRS. Yes.
Yes.
That way, you reduce the morbidity.
Another way is तुम्हारे पास अगर फ्लेक्सिबल नेप्रोस्कोप है तो वही सेटिंग में तुम करो ना. क्यों क्यों सुपाइन करना है? वही वही पंक्चर में से फ्लेक्सिबल स्कोप डालो. जो
Again,
कैलिक्स में जाना है वो कैलिक्स में जाओ और वहाँ वहाँ फ्रैगमेंट करो. तुम्हारे पास
correct.
लेजर
Again,
है.
flexible nephroscope is a stout instrument. It is not as thin as our flexible ureteroscope. So immediate next calyx, if you want to go, it will be very difficult. But from lower going to upper or upper middle, it will be possible. Immediately next calyx, if you want to go, flexible nephroscope is also very difficult.
Yes, I agreed.
Sir, then flexible URS in the amplats that
कर
can also
सकते
be done.
देखो ऑल इंडियन जुगाड़ एंड परमुटेशन कॉम्बिनेशन पॉसिबल है मुद्दा मुद्दा ये है कि तुमको एग्जाम में क्या आंसर देना है तो पीसीएनएल इन प्रॉन पोजिशन बिकॉज यू नो दैट
Yes, sir.
is it possible to do a supine PCNL? Yes, it can be possible. My seniors are doing or our center is doing, not doing जो भी बोलना है वो. Is it possible to do a ECIRS? उसका स्पेसिफिक इंडिकेशन है जैसा सर ने बोला है कि अगर मिड एंड अपर कैलिक्स में जान है ऑलरेडी स्टोन और लोअर कैलिक्स में ज्यादा नहीं है तो लोअर नीचे से फ्लेक्सिबल स्कोप डाल के और क्या करने वाले
So
Sir is
here
trying
what
to
doctor
tell you
Sable
that
एंड
also.
start with
एंड
your
बेस्ट
standard,
एंड
start
बेस्ट
with your
पंचर
standard answer.
हाँ बेस्ट पंक्चर क्या है कि जो पंक्चर से या जो कैलिक्स से मैक्सिमम स्टोन क्लियरेंस होने वाला है जो शॉर्टेस्ट डिस्टेंस है जिसका इन्फेंटिबुलम वाइड है वही वही और वही वही बेस्ट पंक्चर है वो अगर अपर कैलिक्स है तो अपर कैलिक्स है अगर लोअर कैलिक्स है तो लोअर कैलिक्स है नॉट नेसेसरी कि मैं हर चीज लोअर कैलिक्स से ही करूँ या हर चीज अपर कैलिक्स से ही करूँ
Yes, sir.
Dr.
So
तो
what
ये
Sable.
sir? So what sir has said is that you start with your standard answer. If examiner asks you, you know anything else, then you say ECRS, prone PCNL, with ECRS, whatever you want to say.
यस
And third thing is that most of the times, in complex stones, middle calyceal puncture is one of the best.
Yeah, but 70% time you will be able to clear most of the stones. Dr. Sable, you are please your comment on all these things.
Yeah. I'm just listening carefully. If there is a time, then I'll have comment on various things. First is
Yeah, tell us.
first is about KUB. I don't think still we have a choice of not doing KUB at all. So it should be done always in stone cases, especially along with sonography, because KUB gives a morphology of the stone very nicely, and it is a static film. It is very very difficult to imagine the stone morphology or the stone appearance on a sonography. You just have to keep imagining. That is the same thing which happens even with a CT scan, unless there is a good reconstructed images. And about reconstructed images, those are actually computer generated images, though their nice reconstructions are being done with a computer software. So having x-ray, now this was reported as a stag-on calculus on a sonography. Sonography has its own limitations. Sonography, I always say, it's like a story of a seven blinds and an elephant. So whatever they palpate, they say that the elephant is like a pillar or like a tail or something of this. So it is the same thing which happens in a sonography, because at one time only one part of the stone is seen. So as against to that, a simple KUB gives you overall look of the stone. Now here there are plenty of stones in the calyces. So these are multiple calyceal stones in addition to the pelvic component. So it also gives us an idea about complexity. And nowadays, with this sort of scientific discussions, students should be encouraged to say about some stone score. So if they say this is guy's stone score 4, that gives us an idea that they have read about the stone score and they know about the complexities. And once it is bilateral, which is to be operated, I just listened to them. None of them said I will do a retrograde pylography after putting a stent, I mean ureteric catheter. So initially, if you put a retrograde catheter, you put a dilute. If there is a pus, in spite of pus, if it drains thick pus, then probably one will not proceed. But if the pus is not so thick, and you will have to put a dilute contrast, see the system. If the whole system is draining nicely, probably one digestant would do a job. But if there are calyces which are not filled, or there are filling defects in the calyces, which probably suggest, in addition to the stone, there is some debris inside, which may be old stale clots, or which may be pus flakes or whatever, or at times even fungal balls. So in that cases, it may need additional nephrostomies, which will PCNs, which will depend on what all things you want to drain. At times, you might have to drain all three major calyces through three separate PCNs if it is a thick pus. Now there are studies available where the drainage with PCN has not been proved superior to the DJ drainage, but we are always having, because we can put a small large bore catheter. Normally we put 12 to 14 for a thick pus, and it keeps on evacuating. Then about putting bilateral DJ stents, there is one important caveat. There is always a possibility that one system is infected, the other system is not infected. Then in that cases, putting bilateral stents up front is likely to give a passage of one-sided infection to the other kidney easily. So this also has to be borne in mind. In that cases, it is better not to stent the uninfected site, or you put a PCN on the infected site and don't put a DJ stent on that site. So putting upfront digestant bilaterally will be helpful to drain the kidneys. And this is always so. Anytime if somebody is doing bilateral stones, the criteria to choose, I heard, it could be the which is better functioning or painful, and the practical aspect is always there. Try to clear one kidney at a time. So whichever is a lesser burden which can be cleared up easily, that gives multiple advantages. The first is it saves one kidney. Now you have a liberty to operate the opposite kidney at ease. Secondly, it increases your own confidence. It increases the patient's confidence in you that you have cleared one kidney. And whenever there is a large stone burden, one has to always counsel that the patient may need more than one setting. Chance of bleeding blood transfusion is there. And in spite of all these efforts, 100% clearance cannot be assured. So there you might have to quote. So all these aspects have to come into the treatment of this. So at times, if the opposite side is going to come for surgery early, then in that cases, if it is not infected or there is no pus coming out of this thing or no infected fluid, one may temporarily skip putting a digestant if the opposite side is infected. Otherwise, draining both the kidneys upfront is always helpful, because there are plenty of studies where there is a lot of discordance between a urine culture and a nephrostomy culture, because there is some element of obstruction everywhere. Okay, sir?
Oh, thank you.
So,
Thank you very much.
so 2 point. Thank you, sir. 2 points. Just I want to add. X-ray QEB. Doing X-ray QEB is, as sir has told, necessary, but it will not replace the need of doing a CT scan. So managing such type of stone, CT is always necessary. Without doing a CT, only X-ray will not suffice. Only sonography also not suffice, and sonography plus X-ray is also not suffice. So CT is required for such type of complex stones. Number one. Number two, what sir has told about X-ray, that is true. X-ray to be done. Number three is renal culture and bladder culture. We have a big paper in pathogen of our center is also part of that multinational, multi-institutional study. And in that, if the renal urine shows सिंगल ई कोला फॉर एग्जाम्पल एक भी ई कोला अगर मिला है तो दैट इज सिग्निफिकेंट बैक्टीरिया बिकॉज यूरिन कल्चर of a bladder urine 10⁵ more than 10⁵ is a significant bacteria, correct? And for renal, दो या चार भी मिल गया कॉलोनी काउंट तो उसको सिग्निफिकेंट पकड़ना है. नंबर टू, यूरिन कल्चर निगेटिव आया है और सिस्टम ऑब्स्ट्रक्टेड है, दैट डजंट मीन कि सिस्टम इज स्टराइल. So उसके proximal to the obstruction there may be a definitely chance of infection. So that urine culture sterile in preoperative way where the system is completely blocked, that doesn't have any significance. Doing a opposite side digestenting is decision should be very balanced. If it is really necessary, if that system is also blocked and the block the diversion is really necessary, then only do a opposite side PCN or digestant. Then yes, that's all from my side.
Yeah. So concluding, both of you, it's very simple. Right side, we have agreed what to do, as Dr. Sable said. What everyone missed was to do a gentle RGP whenever you are, not proceeding with, for a PCNL, but you want to put a PCN. So best thing is do RGP, find out whether it is draining properly or not. If it is not totally obstructed, just put a digestion. Otherwise, decide where you want to put a PCN.
Sir,
So that is one thing.
RGP is a standard procedural step
Correct.
for doing the PCNL.
Yes.
And while
Yes.
describing the PCNL, they must have tell that because
Yeah.
cystoscopy, RGC and RGP इसके सिवा आगे पंक्चर को जाएगा ही नहीं कोई भी वो
Also
सुपाइन
happen.
सुपाइन
Correct.
रहो नहीं तो
Yeah.
ये रहो until and otherwise you are planning for sonography guided puncture and sonography
Yes.
guided PCNL then there may not be a role for doing RGP or RGC.
I
Sorry,
just have,
RGP.
sir, I
So
just want to add one point regarding RGP because we have discussed RGP 2-3 times.
yeah,
That one plain shoot you should take and save it on the neighboring screen. Sometimes it happens that in small stones also, especially that you do RGP and then you don't know now which calyx you have to puncture.
correct.
So you should always have a plain film shoot. And I personally do not do RGP in while doing cystoscopy. Only after puncture, when my needle is there and I have marked the stone, then I do RGP and I save the same plain film and then take the puncture. Because sometimes you get confused which calyx to puncture. The stone
Sir,
bearing calyx you can miss.
right, doing a RGP is to know only the anatomical roadmap,
Correct, sir. Correct.
Uh,
and it will augment for the site of puncture.
Yes, sir.
uh, can I add something to this?
Yeah, please.
Basically, uh, RGP, I have been always doing. So I always save the initial stone image on the second screen. Take a snap on my mobile, keep it ready for subsequent, and then I do always insist to do a RGP in lithotomy position because if you are going to do a prone PCNL and if you initially put a contrast gradually and take a video of the same, you will realize that the contrast which is reaching to the calyces first are always the dependent calyces. So it happens quite oftenly that in a prone position, the calyces do not feel at all, the dorsal calyces or the posterior calyces. So if you have a lithotomy position RGP and you are planning for a lower calyceal or posterior any posterior calyx puncture, then this helps a lot quite oftenly. This is one I always use at. Secondly, I call something as a calibration of the infundibulum. I simply use what our metal dilator. I keep it on the abdomen by the side of the infundibulum, which I am likely to puncture, which is a broader infundibulum, and this gives me an approximate idea what size amplas I am likely to take it across. So that is also very useful, simple, practical trick during. So in doing RGP with minimal contrast, allow it to puddle into the posterior calyces and locate those calyces, save that video, and you calibrate the infundibulum. So accordingly, what size amplas is going to go easily. One can really take help of these images also.
Now,
That
very
that
good.
is
Thank
that
you.
is that is true, sir. But doing a RGP is a part and parcel of PCNL.
100%.
You
Yeah,
you
yeah.
100%.
you you do in supine, you do in supine as well as
100,
prawn before
100%.
puncturing.
No, no, that discussion has not come into students' picture. So, without RGP, I don't think anyone will be able to do.
Exactly.
Yeah.
Periurethral catheter helps. Even, sir, you said about sonography. In spite of using sonography for puncture, still it is better to have a periurethral, ureteric catheter in situ because it is those images on sonography to dilate adequately. Neither the sonologist is so confident nor urologist whether we are counter perforating.
And
So
sir, sir,
we are
sir,
always very well versed with doing dilatation under fluoroscopy. So there also our X-ray KUB comes for handy. Okay, where was the pelvis and are we going across?
that is true. But some centers are propagating the only sonography guided PCNL. As far as exam is concerned, standard PCNL, whatever described in Campbell, you have to.
Absolutely.
Correct.
Totally
No
agree.
doubt about it.
Totally agree. Totally agree.
Absolutely.
And
And for students, the commonest procedure being done at present is a prone PCNL. So they should be telling about that. They can very well say there are few faculties at our place or at few places PCNL, prone PCNL or ECIRS being done, but we are not doing it regularly. But I will prefer a prone PCNL.
So all four of us are giving you one clear message. Talk about standard first, and if asked or if options are asked, you can say other methods can be done.
then another important point I want to add to Sable sir's here discussion is it is not necessary to place ampoules every time in the pelvis. Correct. And until line, otherwise it is necessary. It is if it is a complex stone, then okay, you will that clear the calyx and go to the pelvis, and from pelvis you can manipulate. If it is only a calyceal stone and for sometimes small calyceal plus small pelvic stone, ampoules can be placed inside the calyx only if it is dilated and the space is adequate. So dilatation of the infundibulum is if it is necessary only, then only you have to go across the infundibulum inside the pelvis. Otherwise, majority times infundibulum are small, ampoules size is probably more than 24, 26, जो भी तुम्हारे पास करते हैं, तो unnecessary you will create a trauma to that infundibulum. So size of the infundibulum, need of the ampoules to place inside the pelvis, size of the stone, if it is involving all the calyces, then only you can place the ampoules in the pelvis. Otherwise, placing the ampoules in the dilated calyx will suffice.
Actually, as far as students are concerned, they should always say, I will dilate initially only up to the calyx. And any infundibulum to see one should see it inside with a nephroscope. And then if the ampoules can be easily negotiated across, then only there is a point and need. Otherwise, that is optional. Remaining in the calyx and going to the pelvis and tackling the pelvic stones is always feasible, and one can use a scope accordingly. So one cannot decide what size ampoules is done only on a preoperative investigations. So it should be a decision on table also at times.
So what both sirs have said is that on table you progress slowly after
Correct.
puncture.
Correct.
True, true.
Okay, now talk about some complications. Okay.
We have got one more case also.
Okay, sir.
Can we go ahead?
Sir,
Only one point I want to make it very clear, means listening to Dr. Sable, you and Dr. Venkat on the left-hand side. So if you put, there is a right-sided purulent urine and the left side is clear, as Dr. Sable said, you can avoid putting a digestant if there is not much of the hydronephrosis. If both the side is infected, put a digestant. Or if you are planning, not only this case, if you are planning that in next 3 or 4 days, I'll be going ahead and doing the second side, again, you can avoid putting digestant. So I think this completes about this case. Rahul, just show them what we have done and then go ahead with the second case.
the complications are the second case, sir.
No, first just show what we have done
Yes.
and then show them the complication. What we did in this case.
Yes, sir.
Just show them. So we did the one side, right side, we did PCNL, multi-loop puncture, and it took a very long time, about 2.5 to 3 hours. So we stopped. And second time, we again went inside on the right side. We cleared the stones. Initially, there was some bleeding. So next time there was no bleeding. And then we completed the left side also. So in 2 sittings, basically we had completed both the side. Only now one stone of 1.5 centimeter or 1.4 centimeter is left behind on the right side. Just show them what happened.
Dr. Gaurang,
Yeah.
one more thing is about flexi-nephroscope or flexi-ureteroscopes using
Okay.
during PCNL. It appears really lucrative to use these equipments, But if you try it, then you will realize the length, the bending segment of all both this nephroscope as well as cystoscope is a sizably longer element, and
Correct.
it is not so much useful in a, for adjacent calyces. They are from lower calyx to reach to the upper calyx. Yes, they are good, but means theoretically it appears very lucrative, but practically using it is not so much useful to reach to all the calyces through a nephrostomy. They may be useful to reach through a ureter. Ureter you can
Hmm.
reach to all the calyces much better, or at times if there is a superior calyceal puncture, then you can reach to the middle or lower calyces better, but not through a lower calyx or a middle calyx to reach to the adjacent calyces.
Correct. Correct. Yeah. Okay. Go ahead, Rahul.
Uh, Sir, am I audible?
Yeah. Now you are audible.
Yes, sir. So we have a short case regarding as a continuation of the previous case, sir. This is another patient.
Yeah. Go ahead.
6-year male presented with incidental finding of renal calculi when he underwent USG as a routine screening procedure. Patient is a known case of hypertension and had undergone multiple stone surgeries in the past. Right PCNL 2 years ago and 4 years ago.
Can't hear you.
We can't hear you. Oh.
Rahul.
Sorry, sir, there was some issue with the connection, sir. I just start
Yeah.
the screen share. Yes, so this was the history. All the blood investigations were normal with serum creatinine 0.8, hemoglobin 14.6, WBC normal, and platelets were also normal. This was the preoperative X-ray in the patient.
Okay.
These were the CT findings in the patient, if anyone would like to comment on this.
Excuse me.
Yeah. Ashray, quick.
Sir, this is a con contrast CT KUB arterial film showing left-sided gross hydronephrosis with multiple calculi in the one in the lower pole and one in the pelvis with multiple small calculi in the lower pole, and the opposite kidney is normal. The surrounding organs, the liver and spleen appear normal. Yeah, and the bony structures
Then
also appear normal.
Opposite kidney, see carefully.
it is lobulated.
Mm.
It
It is
could be
smaller in
seen.
small in
A
size.
little smaller in size.
Mm.
Yeah. Okay. Just city finding.
The interpretation of the CT was a 14 millimeter obstructive PUJ calculi with moderate to gross hydronephrosis, a large renal pelvic calculi on the left side of size 17 by 16 millimeter with multiple lower calyceal calculi. And on the right side, there was a non-obstructive lower pole calculi of size 10 millimeter and 3 millimeter with no hydronephrosis.
Fine. Okay. So this is a
Mm.
short case. We don't want to go much into the details. Right.
Functional, sir.
Ankit.
Yes, sir.
Ankit is there?
Yes, sir.
Yeah. So what you will do?
Sir, since he's a recurrent stone former, I would like to have some his serum calcium PTH level and basic and would like to evaluate further with with stone analysis and 24 after clearing him of the stone after 2 to 3 weeks, then I would like to go with 24-hour urinary examination, sir.
Okay. And now in this case, what you like to do?
Functional
And in this
scanning.
case, sir, first of all, I would like to go after CT scan. There is some delayed excretion in the left side, so I would like to go for the DTP or the
Function.
renal scan.
What you like to do? Left sided?
Did
Sir, first of all, I would like to
Mm.
have some nuclear scan to get a better
DTP.
drainage pattern. So and to also to get the GFR of the both the
So
kidneys
there is an
and
obstructed, so there is a stone in the left pelvic LSL system. No? Just see properly. See in the CT scan, that is all.
mm,
Yes, the PUJ stone.
you just like to put a stent.
So
You
I would
don't
like
want
to
to do
Your
left,
sorry,
the
sir.
left sided PCNL.
I can give a option patient. I can give a option to patient that we can go for RIRS or PCNL, sir. Both can be done, sir. In this.
Yes.
No, I
Pre-standing
want
followed by
you to.
RRS.
First of all,
No,
I would like
I'm the patient and I'm saying, "Ki, doctor, you decide what you want to do."
So standing followed by
all
RRS.
RIRS.
Why you want to do stenting?
What is the size of the stone?
So considering the
14
stone,
mm, sir.
14 mm.
17 mm is the large one.
How many stones?
Multiple.
Multiple stones, 17 mm into 16 large
So,
renal pelvic stone. So
so
your better would be PCNLs.
PCNL, sir.
what is ideal indication for RRS?
A
Less
stone
than
less than 2
Less than
centimeters.
20 mm.
So if you are a student and telling RRS as a primary treatment in exam, you will not get passed.
So first and foremost, let me ask you: have you seen the system?
Again, I am coming on that also.
It's so dilated.
It's
In
a
such a dilated system, if you think RIRS is very easy, small
No,
stone,
sir.
na, you will be lost.
So,
It
so,
is like catching a small fish in a big ocean.
so please don't go with what your consultant is doing at your hospital. Just थोड़ा सा दिमाग लगा के जो जरूरी है वही बोलना है। मैं तो इसमें RIRS नहीं कर सकता ऐसा नहीं मैं बोल रहा हूँ क्योंकि अगर सोडा सर RIRS इसको कर देंगे मैंने इससे भी कॉम्प्लिकेटेड पेशेंट उनको भेजा और उन्होंने किए लेकिन एग्जाम अभी अभी तो हमको पहले तो कागज लाना है वो पास का बाद में तुमको जो करना है करो।
true. Basically,
Absolutely, absolutely, I agree
this
with sir.
dilated, this is a dilated system. Doing PCNL will be far easier than keeping on searching for stones on RIRS. The collective stone burden is sizable stone burden and not upfront advisable for students to say RIRS for this. And somebody said about function. See the subsequent images, it definitely shows a function on both sides, reasonable function. So whenever there is a function seen on CT scan, I don't think there is a point in additionally asking for DTP or anything, because it is a functioning system, and we are not going to knock off the kidney on with this sort of images. So only thing is, if at all you want to have a baseline study for a counseling and subsequent follow-up,
Sir,
that's the only indication, but that is not the case every time.
If this was a high
sir,
risk
sir, sir,
patient and you
sir,
had to do
cons-
RIRS, if
con-
this was a high risk patient and you had to do RIRS, one tip, one trick or tip would be to use a suction accessory. By that way, you will be able to reduce the hydro, and also it will be easier to tackle the stone.
नहीं
Rahul, just show them the.
I
Rahul,
am
बच्चे लोग
sir, sir,
को
sir,
X-ray दिखाओ.
sir, 1 minute. I am just differing with Savle sir's opinion about doing the DTPS scan because sir is telling is correct, but as far as कैसा है कि current जो social situation है बाद में post operatively if anything goes wrong then the first that relative will come and say you were due to your operation only my kidney has gone. So basic function, if this is not an undilated or mildly dilated system, this is a moderately or severely dilated system. In spite of the having a uptake of contrast in nephrogenic phase, better to tell and do also. That's what I feel. In such
Parenchyma is
type of
also thinned
cases,
out, sir. Parenchyma is
and in
also
such
thinned.
cases, DTP scan exam में भी बोलना है और better for your protection do it.
Yeah. Parenchyma is also not that great. It's mildly thinned out.
Yeah. Okay. So just see the stone on X-ray. Do you think a RIRS is easier, even
No,
with
sir.
this size of the stone and
No,
No,
multiple
sir.
stones?
No, sir.
no,
Not easy
no,
at
sir.
all. Not easy.
Okay. So what are the complications you think that it will occur because of this dilated system? Already operated 2-3 times.
Difficult access to the system. Then bleeding, chances of bleeding.
So chances of
Bec-
bleeding would be high.
Bleed high.
So first of all, there may be a fibrosis, correct?
Yeah, yes, sir.
Yes.
So to dilatation of the tract and everything will be little difficult. Puncture may be little difficult. Second, the anatomy may be little distorted.
Distorted.
Then
Intra bleeding, maybe chances of bleeding and stone migration.
why? Why?
So because of the thinning of the
Because of
parenchyma, because
One
of
is the
the
thinning of the parenchyma.
parenchyma,
Second,
because of the gross dilatation of the hydronephrotic kidney, so there is more chances कि stone may get dispersed, and we may have a difficult time in assessing. And he has been
you're
underwent
talking
the
of bleeding.
multiple PCN.
You're
Yes, sir.
talking of bleeding. You're talking of bleeding.
Okay.
First, tell me, you are saying that there are more chances of bleeding. Why?
Bleeding.
Sir,
so
because they are
prior
going
history
through
of
the scarred
PCNL was there.
Prior
parenchyma.
history of
Prior
PCN
history of PCNL was there.
So what?
So through the scarred area.
There
So
can be
retraction of the vessels may be
distorted
less.
anatomy. So
Distorted, and then we might puncture it.
Then is a thin parenchyma. So there is not enough of support,
yes,
Yes.
right?
Yes.
yes.
In these
So there
dilated
are
systems, the parenchymal purchase is very less. So, sleeping of your guide wire or amplastic, both are possible. What type of dilators one should prefer in this case, dilating system, in a redo cases?
Right.
Alkanes dilators.
Alkyl metal.
Basically,
Telescope.
telescopic metal
Telescope
dilators,
dilator.
alkane metal dilators should be
Dilator.
preferred for in cases of a fibrosis, because it is going to keep a constant tamponade and track loss is less likely.
Yes.
So, one more question with regard to Sablis's question. Suppose your facial dilators are not going in. How will you dilate the fascia? Because of fibrosis, it is quite tough.
So
It's
with
not
help
going.
of we can do with help of artery forceps also, sir.
No. Never say that. You may have seen it, but that's not right. You have got a nice guide wire placed in the PCS. Facial dilator is not going in. Anything related to alkane dilator set,
So then Alkane single step, we can use the needle with the sheath 8
what
French.
is it called? Alkane cannula
Alkanes,
with the
yes.
half sheath. What is the purpose of that half sheath?
So if there is any, it aligns it. If there is any distorted
No,
track
so
or then
alkane cannula is a metal cannula. It's like a facial dilator. It can be used in these difficult cases where there is fibrosis. So you dilate that fascia and then you move that half sheath inside, take out the alkane cannula, and through that half sheath you can put in the guide rod. Then you can take out that half sheath. That is the
yes.
purpose of the half sheath.
And if you are
Any other way, any other way of using dilating the fascia? With the guide rod, you know how to dilate the fascia? So the guide rod has got a bead in front. You cannot use the beaded end.
We
You
have
turn
put
the
the
guide,
sun down.
you
And
turn the
upside down,
guide,
sir.
Upside down.
you turn the guide rod around. So at the other end there is a conical part. So you put the guide rod in the reverse way, take it out again turn it and put the beaded end inside. So these are the two tricks of you dilating the fascia. Sorry, Sable sir was saying something.
basically in puncturing these systems, flabby systems, you need a fresh initial puncture needle. If it is not a sharp needle, the parenchyma will just keep on getting pushed ahead rather than getting punctured. So you have to
Absolutely.
ensure that you are puncturing with a sharp tap rather than otherwise instead of pushing gently ahead. Because if you keep pushing the blunt the needle, it will just keep pushing the thin parenchyma ahead and ahead. So you need a sharp tap to enter the thinned out parenchyma.
So here can we use a Cobra catheter and over that we can put an amplas?
That is also possible. That is also possible, but if you are going to use a Cobra catheter or rail, in that cases you will have to use a facial dilators, not the metallic dilators.
Metallic, yes.
Metallic dilators is a part and parcel. The guide rod is actually part and parcel of a alkane dilating system. The total
Yes.
name is alkane metal telescopic dilator
Telescopic
set.
dilator.
And
Yes.
the important fact about alkane metal dilator system is you should have all your dilators in the system available. You don't have chance to miss or skip any dilator like what we do in a facial, because if any dilator is missing, the system is useless. It will
Yes.
core out a biopsy from the kidney, because the every subsequent dilator has a lock at the back end, which does not allow overriding of the next dilator or the previous dilators, which is a safety mechanism.
Yes, sir.
So right side, what would you like to do, Samit? You are muted, Samit.
Sir, right side there is a non-obstructive lower pole 10 mm and 3 mm, sir. So for the right side, can go ahead with RIRS, sir.
So what would you like to do first, RIRS first or PCNL first?
So here I would like to place a stent on the right side and then go ahead with left side PCNL, sir. And then in the next sitting, the right side RIRS and remove the left side stent and then finally the right side stent removal.
Ankit, you agree with him?
Yes, sir. Because the left side is obstructed system, so I would like to tackle the left kidney first and put a DJ stand on the right side so that we next time when we go, we have a easy access to the for our access sheet for our IRS.
Samit, what about you?
Yes.
Sir,
So your wife has told you to go what other two says? Or you are going to use your own brain? This patient has come to you. He has got a one small stone on the right side and he has got on the left side multiple stones. You are planning for left-sided PCNL. For that
yes.
small stone, you want to subject him twice anesthesia.
Because he's a recurrent stone former, there
This
is
one.
See,
so we
nowadays you don't need to pre-stent every patient. There has been miniaturization of scopes. We have better access sheets. So you have to tell the patient, you have to counsel the patient that I will try and calibrate the ureter. If the ureter is good and my access sheet is going up, you will finish RIRS in one stage. How many stages you will give this patient? Sir is telling you, na, he's giving you a hint that there is a small stone. Just in case the ureter is tight, then you would like to put a stent and maybe then tackle the left side. But otherwise, you can finish RIRS and even start with the PCNL on the left side in case of a small stone.
So fine, but we did the right RIRS and we did the right left PCNL. Okay. Now the patient came with the hematuria. So what are the causes? Ankit.
yes, sir.
Now this patient, after 4 to 5 days, he went home and he has telephoned you and he has sent the first on the left hand side. He has collected urine and sent you on a WhatsApp. Okay, doctor, this is urine which I'm passing. What will
Sir,
do?
I will
He is
ask the
not in the
patient.
hospital. He
Sir,
is
I
not
will
in the
ask.
hospital. He has already gone.
Sir, I will ask the patient to immediately report to the hospital, and I will get. I
Very good.
will admit. I will admit the patient, and we will look for the vital and arrange blood for the transfusion before, and we will get a ABO profile and make sure that we have a
So you
blood
will do
arrange.
all the
And
resuscitation method,
yes,
correct?
sir. Yes,
Now,
sir.
but this patient was not in Mumbai that time. He had gone to his small town. He says, Doctor, I will take some time to come to Mumbai.
I will make sure the sir, all the patient and everything has been removed.
No, no,
Just
he
wanted
has,
to know.
he was absolutely fine when he left your hospital. When he left our hospital, this is a fact I'm telling you.
Mm.
He was absolutely fine. He had no hematuria, no fever,
You
nothing. We do regularly, we do CBC, creatinine, even the urine
Mm.
routine to see if there is not innumerable RBC or pus cells. Otherwise, we
Mhm.
keep and give antibiotics and keep the
Mm.
patient in. But this patient, when
No,
he went, he was absolutely fine. But after,
देखो
I think, 6 or 7
sir,
days, he showed me this. And he's in his small town. Now, what you will do?
Sir, I will ask him to go to the
from the
nearest
nearby
hospital.
hospital.
yeah, exactly.
Very
We-
You should answer this question very diplomatically. Nowadays, the urologists are available at district places also. Correct, in the state
Mm.
of Maharashtra, and I will search he is from which place and who is the nearest urologist. I will talk with the urologist as well as I will talk to the patient and go and attend that urologist.
fine. So, exactly that is what we did. But then he came to Mumbai. So now he has come back to you and he has got
Mm.
hematuria. You have examined you, his BP is okay. His hemoglobin was, when he left, it was 12, I think about 12.2. And when he came again, it was 11.5. There was not much difference. His BP, pulse, everything is fine. So now what you will do?
I will
In
like to search for the cause of the hematuria. Like there may be some infection, or there may be some pseudoaneurysm or AV malformation may be there. So I would like to conventional CT, and I will do conventional CT angio after
Immediately,
stabilizing the
Sir,
after
first
stabilizing first of the after
X-ray to look
stabilize.
for position of
every
stent.
case of
Then
hematuria, immediately you do angio.
no, sir.
First,
Firstly,
first
see,
imaging to
First
X-ray to
image.
see the
see,
pattern.
Ultrasound.
just listen to the story what sir told. Patient had gone home fine. After a few days, this was a urine. Then subsequently he had come back again. So it must have been a period of 8 to 10 days or maybe more. And
Mm.
this is a amber color, dark color urine. It is not a fresh color. So do you think this is arterial bleeding or AV malformation bleeding?
Sir, it is a venous
Can this
bleeding.
happen? This with a just a dilated system getting decompressed and giving this color? Is it possible? And somebody's hemoglobin has just dropped by 1 at the end of 10 days. So is it really a warranting situation that you have to do immediately a angiography? Yes,
Mm.
doing all the measures, keeping blood at hand, and monitoring the patient is essential. But adequate hydration, might be some injection pause. If there are clots in the bladder, what has been shown on the right side, you might have to remove them. And you initially attempt a conservative treatment. And then there, if at all, there is a role of angiography if it keeps on bleeding.
Exactly. So you give good antibiotic, you hydrate the patient. Of course, there are many things which I like to do, which is not very scientifically. I will not say like calcium. Sometimes we have given blood, calcium gluconate, vitamin K, whatever it is. But first, conservative line of treatment you have given. In spite of that, if the patient has got bleeding, then you will like to do what you like to do, Ankit.
Uh, so, baseline USG would like to do, and followed by CT scan.
Why CT scan?
The baseline USG and X-ray
USG,
KUB.
X-ray KUB.
Why ultrasonography? No, no, I'm not saying you justify. Now, why you want to do sonography?
Sir, as an
Sir, no,
देखो
extension of my physical
no,
examination to look for perinephric
no 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 no
hematomas
no
or
no no
No,
no
no,
no
no.
no
malformations.
It is
so
not
listen
part of physical
listen
examination
listen
now.
what sir has told or given the scenario. You have to answer as per that, na?
So to look for any
So to
clots
look
in
for
the
bladder
pelvic alicizal
clots,
Yeah.
systems or bladder clots.
position of the stent, and also residual cal and clots in the PCS.
Clots in the pelvic calcium system or any perinephric
Fluid.
collection
Hematoma or
or
bleeding or
yeah.
retroperitoneal collection.
Very good. So you will do sonography, correct? So I
Yes,
did a
sir.
sonography and it showed 70 cc clot in the bladder, and no perinephric fluid, and the kidneys were okay.
Hmm.
Now what will do?
Sir, insert a three-way
Three-way
Foley's
Polish
catheter.
catheter
So
and start
three-way Foley's
irrigation.
and give wash and then start with irrigation.
Irrigation for
So,
20 to
You
48
think that
hours.
this type of clots will come out with this?
As a primary measure, and
It
then
can.
start eventually will require a clot evacuation.
So why not immediately? Why to trouble him? Every 2 hours he will come with a clot retention. He will be there. You will have to keep on giving him wash. Finish it off now. Remove the
yes, sir.
clots. So that is what we did.
Yes.
We immediately removed, and we saw on both the side, and already to this was a 14th or 15th day. We decided to remove the DJ stent also. So we removed the DJ stent and we removed these clots. Okay.
Yes.
Do you have anything, any video on that?
Yes, sir, there is a video. Just a minute, sir.
Dr. Gaurang sir,
Bolo.
uh, mm, I had published a point of technique about these minimal clots in the bladder. If the
Huh.
patient is not reluctant for any subsequent intervention, anesthesia, or subsequent expenses, so they can be managed conservatively. I do a simple trick in these cases. In a three-way balloon, I keep half of saline and half of air. So 15 cc water and maybe 10 or 15 cc air, and allow the balloon to float in the supernatant and keep giving slowly irrigation. So quite oftenly the body urokinase do take care of these minimal clots.
Okay. Fantastic.
This
In
is a
small,
simple point of technique.
yeah, in a small clots, some few we will try once.
Yeah. And now I'm going to modify this technique a little more. I'm going to put a metallic bead at the tip of the Foley's catheter, suture it with a suture, and make it a short magnet on the abdomen so as to keep the tip of the Foley floating persistently.
Ingenious.
So he can be ambulatory and still the balloon will be much higher up. The draining channel will be higher up and will not. Normally, what happens? The clots are at the bladder neck, and once they surround our catheter, so immediately after catheterization, put air as well as this thing, and it will keep floating. I have images to that effect, CT as well as X-ray, where sonography, where it shows that the balloon is floating at a supernatant level.
Wow. Okay. Anyway, so we remove the clots. Okay. Now the question is that patient, when we again did his urine, okay, yeah, he's showing. So these are all clots. Huh?
So the DJ stent was removed, and then the clots were there in the bladder, which are being shown in the
Yeah.
video at present.
Yeah. Correct. So we removed the clots. Now patient has come again and he has got pink color urine and it is innumerable RBC. So Ashai, now what you are going
Sir.
to do?
Sir, I would like to check his hemoglobin if it has fallen and his
No,
vitals.
hemoglobin is not fallen. Now he is within I think 2 or 3 days are over, but he has come back. I mean, he has
After
done his
DJ
urine and
removal.
it is showing. Pardon? Yeah. After
After
removal, I
DJ.
showed you, all the
Uh,
clots are out.
okay, sir. Sir, during cystoscopy, was there blood coming from the
No, that
ureteric
we could no
orifices?
no. We removed the DJ stand. There was no blood coming from DJ stand or from the ureter.
And was there any bladder mass on cystoscopy? No.
No, everything was
Oh.
fine.
Sir, then if it is a faint hematuria, then uh, it might be due to small parenchymal or mucosal bleeding, which will resolve with hydration and observation. if the hemoglobin
So
is
you
not
like to
dropping.
observe.
I will
Okay.
reassure the patient and observe.
So now he has not come back. Now if he again comes with the clots, what we will do?
So then
Then,
then there will be role of CT.
Sir,
Why
first of all,
CT? Why you
we
want to do CT?
sir,
sir,
first of all, I
first
will
of all, we'll
evaluate the patient, his
Evaluation enough.
vitals and
and rule out
hemoglobin,
UTI, sir.
and then according to that, consider admission. Then put a catheter,
No, he has second time
evacuate the
when he
clots.
comes with the second time he comes with the clots, what you are going to do?
First
Are you
of all,
going to
we will
sit on him?
Cystoscopy.
first of all we will like to exclude the infection, whether he's having any active UTI or not, and we'll look for any
No, he is
perinephric
already
fat
on good
standing.
antibiotics, na? Ankit. We have removed the clots.
Yes, sir.
He is already on a good antibiotic. Whatever the culture was there, he is already on injectable antibiotics. I have given him for 10 days now. And I'm regularly doing. But again, if he has come with the clots, what you will do?
And then,
I
But
agree. You will admit him. You will see the substitute. You will do all the investigations. You will keep the blood ready. Everything. His
sir, is
hemoglobin
there
has not dropped too much.
is there anything on the imaging like a residual cal or any mass or
No,
anything?
nothing is there.
we will like to evaluate the upper tract, sir. Source of bleeding I
Hey,
want to
Baba,
identify.
Ankit, Ashay, Samit, I am not asking you some difficult, it's not a tricky. I'm just telling you that again he has come with the clots. Second time, first time he came with the clots, you removed the clots, everything is fine. Again he has come with the
So
clots.
in
Now what
other
you will
words,
do?
sir is trying to tell you that first time you could have thought that it is old blood, but now
Hmm.
again he has come with clot.
देखो
So
you
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 should do
you you
something else or no?
you
Sir,
should
is this the
you
anticoagulation profile?
you
Coagulation
should
profile also?
listen.
Yes, sir.
You should read the mind of examiner. When he is telling second time and there is still hematuria, persistently sir is insisting second time why you want to do a CT. दूसरा क्या बचता है भाई कन्वेंशनल सीटी कन्वेंशनल एंजियो करके उसमें जो भी है ढूंढ के उसको ब्लॉक करने के सिवाय दूसरा कुछ बचता है क्या ऑलरेडी कंजर्वेटिव का डिस्कशन खत्म हो चुका है
He's
सेकंड टाइम
Yes,
ब्लीडिंग
sir.
हुआ है
he's giving you
Yes,
hint.
sir.
You all are not
Yes, sir.
picking it up.
हाँ
First
एग्जामिनर
time
इज
it
consistently directing towards this thing and you are not picking.
first time it could have been old blood or something, but second time he has come bleeding. You have to do angio, na?
Yes, sir.
Simple बात है.
DSA angioembolization.
And in such, if you are planning angioembolization, there is no role of CT. Why you want to do CT? Already patient is compromised. You do CT angio, lots of money, exposure, radiation, and contrast. And then you say, okay, you have got a bleed, I have to do angio embolization. Why?
Yes.
You already done ultrasonography, you know there is no extrarenal fluid, there is no other complication. It is a pure bleeding. So what are the reasons for bleeding?
Sir,
Pseudoaneurysm.
delayed post-op bleeding can be due to pseudoaneurysm or
Pseudoaneurysm
AV
or
AV,
fistula.
AV
AV fistula.
malls.
What is the
AV
difference between two?
Sir, pseudoaneurysm is abnormal dilatation of the injured vessels in which the wall is not formed by it is not a true wall of the vessel. It is formed by adventitia, and it
AV
occurs.
fistula is
An AV fistula
AV
is
fistula
the
is
when
abnormal
arteries and
communication.
veins are
communicating
damaged
abnormal communication.
and they abnormally communicate when the edema settles after 7 days and
So
clots
what is the
dissolve.
difference between the bleeding in both the case?
Intermittent in
Sir,
pseudoaneurysm and
intermittent,
continuous and
continuous in
AV
AV
fistula.
fistula.
So in this case, what you
So
expect?
pseudoaneurysm might be there
So
because there
pseudoaneurysm
is
because there is
intermittent
intermittent
bleeding.
clots and dislodging, clot and dislodging.
Right. So that is what we have to do.
Yes,
Okay?
sir.
Yes, sir.
Fine. Any last comment from other teachers before we close down?
Good
Sable
discussion, sir.
sir,
No, sir.
Gite sir.
No, sir. It's nice discussion. Thank you to Sable sir for joining and
Yes.
giving his opinion in between. So we'll
Thank you. Thank you.
Thanks to all the students for joining.
Thank you.
Thank you, sir.
Okay,
Thank
now
you,
I
sir.
think the new batch is joining. They will be, I think, in next 10 to 15 days, they will be
चालू हुआ था अभी
Yes, sir. 10th April.
joining. Already the placement has been done. Correct?
Yes,
Ankit,
sir.
you are the
Yes, sir.
senior most in your institute. So you also must have received, no?
Yes, sir.
Yes, sir.
Yes, sir.
So I can see the smile on your face. Huh?
Yes.
Juniors to help you out. Good.
Yes, sir.
So once they've joined, just tell them to join our classes, which will offer great help to them as well as to us also. Okay.
Yes,
Yes,
sir.
sir.
Yes.
So thank you very much. And we are going to give you all the details. What are the case discussions we are going to do? Fine?
Yes, sir.
Thank you.
Yes, sir.
Okay.
Thank you,
So
Gite
thanks
sir,
to,
Gaurang sir,
yes,
Kapil
thanks.
sir.
Thank you, everyone. Thank you.
Thank
Yeah.
you. Good night.
Good
Thank
night.
Thank
you,
you, sir. Good
students.
night, sir.
Bye bye.
Good night, sir. Thank you, sir.
Good night,
Good
sir.
night,
Thank
sir.
you.
Thank you, sir.
Thank you. Recording is on, na?
Yes, sir.
Yes, sir.
So I have to leave meeting or I have to stop, na? I have to
હું
stop because
હું સ્ટોપ કરી દઉં છું સર 1 મિનિટ.